In 1 out of every 1,000 surgical procedures, something deeply unsettling happens in silence. The patient lies completely immobilized while their mind remains fully active. They can hear the medical team's conversations, feel pressure, and even pain, yet they are utterly unable to move, cry out, or signal in any way that they are conscious. This phenomenon is known as intraoperative awareness, and it stands as one of the most terrifying experiences a human being can undergo within contemporary medicine. If you have ever gone through surgery, or if one is approaching in your future, you have likely wondered what really happens in that dark interval between the moment they ask you to count backward from 10 and the instant you wake up in recovery. Where did you go? What happened to your body? Who was watching over your life? In the next several minutes, I will walk you through every step of the general anesthesia process. From the drug that erases your memories before you even enter the operating room, to the machine that breathes on your behalf, to the precise moment your brain switches back on. At the end, I will share 5 concrete actions you can take before any surgery to make your anesthesia considerably safer. And the fourth one is something almost no patient ever thinks about. But first, let us look at what happens in the 30 minutes before you fall asleep. I am Dr. Mercer, a specialist in senior health with over 15 years of dedicated clinical experience, having worked with thousands of men and women over 60, many of whom faced surgery and came to me with a single question: will I wake up? Most people assume anesthesia begins the moment they lose consciousness, but that assumption is wrong. It actually begins in a preoperative room with a small injection delivered through your IV line, a drug called midazolam, which belongs to a family of sedatives known as benzodiazepines. And it does something quite remarkable. Within minutes, your anxiety begins to dissolve. You feel warm, calm, almost euphoric. Nurses may be speaking with you. You might be exchanging jokes with the surgical team, and yet you will retain no memory of any of it. This effect is called anterograde amnesia, meaning your brain simply stops recording new memories. Everything that follows the injection, the journey through hospital corridors, the harsh lights of the operating room, the faces of the people around you, none of it gets stored. Think of your memory as a camera and midazolam as the finger that presses pause on the record button. You are awake, you are speaking, you are functioning, but nothing is being captured. This is entirely by design, because what comes next is a process the human mind was never meant to consciously witness. Roughly 30 minutes later, a white liquid enters your bloodstream, and within 8 seconds, everything goes dark. You are lying on the operating table now. The room is cold. The lights are blinding, monitors are beeping steadily, an oxygen mask is placed over your face. And this is not merely for comfort. Your anesthesiologist is flooding your lungs with pure oxygen because in less than a minute, you will stop breathing entirely on your own. And that stored oxygen in your blood becomes your safety reserve. Then, through your IV line, comes Propofol, a white milky liquid that some physicians informally call milk of amnesia. You may feel a brief burning sensation traveling up your arm lasting 2 or 3 seconds. And then, in 8 to 10 seconds, your consciousness shuts down completely. Propofol works not by making you sleepy, but by enhancing a neurotransmitter called GABA, which functions like a chemical brake applied to your neurons. Within seconds, communication between different regions of your brain is severed. The frontal cortex goes silent. The thalamus disconnects from the cortex. This is not sleep in any conventional sense, because when you sleep, your brain remains active, cycling through stages, processing information, dreaming. Under Propofol, your brain is chemically silenced, and the pattern visible on an EEG monitor resembles a coma far more than it resembles sleep. Some researchers have described this state as being near death. Your brain is not resting. It has been switched off, and now your body faces an immediate problem, because the same mechanism that silenced your brain has also silenced the region of your brainstem responsible for telling your lungs to breathe. This is where the anesthesiologist's most critical work begins, because for the next 30, 60, or 90 minutes, a machine will breathe for you, and a trained specialist must govern every single breath. The moment you lose consciousness, your anesthesiologist performs one of the most technically demanding procedures in medicine, called intubation, in which a laryngoscope is inserted into your mouth, the vocal cords are visualized, and a plastic tube is carefully guided through your throat, past your vocal cords, and down into your trachea, where it connects to a ventilator that will push air into your lungs and draw it back out at a precisely calibrated rate, volume, and pressure for the entire duration of your surgery. Beyond breathing, There is another challenge. Surgery demands absolute stillness, because if a patient reflexively coughs or their abdominal wall suddenly tenses during a delicate incision, the consequences could be catastrophic. For this reason, paralytic drugs known as neuromuscular blocking agents are also administered, completely interrupting the signal between your nerves and your muscles. Every voluntary muscle in your body becomes still. Your arms, your legs, your diaphragm, your chest wall, everything frozen. Consider the story of Thomas, a 68-year-old patient who needed open heart surgery and told me the night before that he trusted the surgeon completely. But what terrified him was the part where he would not be there. What I told Thomas is what I am telling you now. During every second of his operation, an anesthesiologist sat at the head of the table watching 5 screens simultaneously, monitoring blood pressure, heart rate, oxygen saturation, carbon dioxide levels, body temperature, and anesthesia depth, making micro-adjustments every 30 seconds, a fraction more anesthetic gas here, a slight increase in ventilator rate there, a small bolus of fluid when needed. Hundreds of tiny decisions repeated continuously over the course of hours. The surgeon repairs the body. The anesthesiologist keeps the patient alive. When the surgery concludes and the final suture is placed, the reversal process begins. The anesthetic gases are turned off, and as your lungs continue to be ventilated with pure oxygen, the remaining anesthetic clears from your blood while your liver begins metabolizing the drugs. Slowly, traces of electrical activity reappear on the brain monitor. Think of it like a city recovering from a blackout where the lights do not all return at once but come back block by block, neighborhood by neighborhood. Your brainstem comes online first, restoring the most primitive functions like the drive to breathe and the gag reflex. Then the limbic system returns, bringing with it emotion and orientation. Then the cortex reawakens, restoring higher thought, recognition, and memory. This process takes minutes, sometimes 5, sometimes 15, depending on the drugs used, the length of surgery, your age, and your metabolism. As consciousness returns, the anesthesiologist watches for one critical sign. The moment your diaphragm begins to move independently, the moment your lungs start pulling air without the machine's assistance, that is the signal to remove the endotracheal tube in a process called extubation, which is uncomfortable. Patients may cough and gag, and their throat will feel sore, but because of the midazolam administered at the start and the residual effects of the anesthetics, most patients have no memory of this moment at all. For some patients, however, the waking process is not smooth. Some emerge in a state of severe confusion, agitation, or even aggression, attempting to pull out their IV line, swinging at nurses, or screaming. This is called emergence delirium. It is more common in certain patient populations following certain types of surgery, and with certain anesthetic agents, it is temporary and manageable. But it is profoundly distressing for both the patient and any family members who witness it, particularly because the patient rarely remembers it afterward, while the family never forgets. Now let us address the question every patient is genuinely afraid to ask, which is what happens if your brain comes back online while your body is still paralyzed, while the surgery is still underway. Awareness during surgery occurs in approximately 1 to 2 out of every 1,000 cases, which means that in 998 out of 1,000 surgeries, it does not happen. But when it does, the experience can be deeply traumatic, with patients reporting hearing voices, sensing pressure, and in rare cases, feeling pain, all while being completely incapable of moving or communicating. Modern medicine addresses this risk through brainwave monitoring technology called BIS, or bispectral index, which tracks the depth of anesthesia in real time and displays a number between 0 and 100. A reading of 100 means fully awake. The target range during general anesthesia is between 40 and 60, and anything below 40 suggests the anesthesia may be dangerously deep. The anesthesiologist watches this number continuously, maintaining that narrow band between too light and too deep, because too light risks awareness, while too deep risks cardiovascular compromise. It is a continuous, dynamic balance sustained for the entire duration of the procedure. And to provide perspective on overall safety, the risk of dying from anesthesia in a modern hospital has been estimated at between 1 in 200,000 and 1 in 300,000, meaning your statistical risk of a fatal car accident on the drive to the hospital is actually higher than your risk of dying from. The anesthesia itself, modern anesthesia, is among the safest medical interventions in existence, not because the drugs carry no risk, but because the monitoring, the training, and the precision surrounding their use have reached a remarkable level. Now, here are the 5 things you can do to make your own anesthesia safer. First, disclose every medication and supplement you take, including over-the-counter products, herbal remedies, vitamins, fish oil, St. John's wort, and CBD oil. Because many of these interact with anesthetic agents in ways that affect blood clotting or how your liver processes the drugs. Second, be honest about your alcohol consumption, because this is not a matter of judgment but of pharmacology, and chronic alcohol use alters how your liver metabolizes anesthetic drugs, potentially requiring higher doses that an uninformed anesthesiologist would not anticipate. Third, follow fasting instructions precisely, because food remaining in your stomach during intubation can be aspirated into your lungs, leading to aspiration pneumonia, which is a serious and potentially fatal complication. Fourth, and this is the step most patients never consider, ask to meet your anesthesiologist before the procedure and say the following words. I would like to understand the anesthesia plan for my procedure. What agents will you use? Will BIS monitoring be available? And what is your protocol for managing awareness prevention? Those words will be immediately recognized and will signal to your anesthesiologist that they are dealing with an informed patient. Fifth, report any previous adverse reactions to anesthesia, whether that means waking up with severe nausea, having an allergic response to an anesthetic agent, or knowing that a family member has experienced complications, because some anesthetic sensitivities are hereditary, a condition known medically as malignant hyperthermia susceptibility, and disclosing this information in advance can be life-saving. Write those 5 steps down and bring them to your pre-surgical appointment. Every day, more than 60,000 people in the United States alone undergo general anesthesia, and the vast majority have no idea what is actually happening to their body. They do not know about the memory-erasing drug. They do not know that a machine is breathing for them. They do not know that their muscles are chemically paralyzed. They do not know that every 30 seconds someone is making a micro-decision to keep them alive. Now you know, and knowing does not make surgery more frightening, but less so, because fear is born from the unknown, and you have just replaced the unknown with understanding.